Okay, good evening, everybody. And my topic for this evening, although the title is Asthma in the Adolescent age group, however, there are a lot of changes in the GINA guideline in 2019 to 2020. So I would also like to update you on the asthma management with the focus on the adolescent pediatrics. And we will also discuss the differences among bronchodilators as well as the interim guidance on asthma and COVID-19. Asthma, we all know, is a heterogeneous disease. It's a chronic inflammation of the airways with respiratory symptoms such as wheeze, shortness of breath, chest tightness, and cough, which varies over time and in intensity, and with variable expiratory airflow limitation. For the diagnostic criteria for asthma in adults, adolescents, and children 6 to 11 years of age with the respiratory symptoms, usually they have more than one type of respiratory symptoms. And the symptoms, as we said earlier, occur variably over time and in intensity. And the symptoms are often worse at night or on waking up. And the symptoms are triggered by exercise, laughter, allergens, or cold air, and usually appear or worsen with viral infections. Whenever possible, the diagnosis of asthma should be documented objectively before inhaled corticosteroids are started. And to confirm the presence of variable expiratory airflow limitation, although this is a busy slide, it just says that you have to document the excessive variability in lung function in one or more of the tests below. One is a positive bronchodilator reversibility test. And in children, the increase in FEV1 of more than 12% predicted supports the diagnosis of asthma. Excessive variability in twice daily peak expiratory flow monitoring over the 2 weeks period, and the average daily diurnal variability is more than 13%. Again, it supports the diagnosis of asthma. Significant increase in lung function after 4 weeks of anti-inflammatory treatment, and positive exercise challenge test. If the child is asked to do your exercise challenge test, there's a fall in your FEV1 by more than 12% predicted, or peak expiratory flow of more than 15%. And excessive variation in lung function between visits. Again, FEV1 more than 12% or 15% peak expiratory flow. What if the patient is already taking controller treatment? How are we going to confirm the diagnosis? Again, you have variable respiratory symptom and variable airflow limitation. The diagnosis of asthma is confirmed. If the patient presents with variable respiratory symptom but no variable airflow limitation, then what can be done is to repeat the spirometry test after withholding your bronchodilators and check between visit variability, and if still normal, consider alternative diagnosis. For patients with few respiratory symptoms, with normal lung function and no variable airflow limitation, the bronchodilator reversibility test again can be done after withholding your bronchodilator. And if the patient is controlled on the present controller, you may consider stepping down. And that if symptoms emerge and the lung function falls, asthma is confirmed, and step up controller treatment to previous lowest effective dose. If no change in the symptoms or lung function at lowest controller, then consider ceasing the controller and monitor the patient closely for about a year. If the patient presents with persistent shortness of breath and persistent airflow limitation, who is already taking the controller drugs, consider stepping up the treatment for 3 months. What about for children less than 5 years? So the patient less than 5 years and younger usually presents with recurrent episodes of cough, wheezing, dyspnea, or chest tightness, seasonal pattern occurs or worsen with viral infection or with laughter, crying, and exercise, troublesome cough at night or early morning, cough or wheeze after the exercise, the colds that go to the chest or take more than 10 days to clear. Symptoms respond to anti-asthma therapy and may vary with time and intensity, and usually they have a personal or family history of asthma, atopy, or allergic rhinitis. And it is not likely to be asthma if the patient has failure to thrive, if it's very early onset or neonatal onset of symptoms, vomiting associated with respiratory symptoms, if it's a continuous wheezing, failure to respond to asthma controller meds, no association of symptoms with typical triggers, focal lung or cardiovascular signs or finger clubbing, hypoxemia outside of vital signs, chronic sputum production, and chest pain. So how do we diagnose asthma upon initial presentation? So if the patient presents and the history and examination supports the asthma diagnosis, you perform your spirometry or your peak expiratory flow with reversibility test. And if the result supports your asthma diagnosis, treat as asthma. However, if there's clinical urgency and other diagnosis is unlikely, you may do empiric treatment with inhaled corticosteroids and PRN-SABA, and review response and diagnostic testing should be done within the next 1 to 3 months. If the patient does not present with your typical symptoms of asthma, then further history and tests for alternative diagnosis should be done. So how do we assess asthma? First, you have to assess the asthma control, and these are 2 domains. Assess symptom control over the last 4 weeks and assess the risk factors for poor outcomes, including lung function. We also have to address the treatment issues such as the inhaler technique and adherence, about the side effects, and each patient should actually have a written asthma action plan, especially nowadays during the pandemic. What are the patient's attitudes and goals for their asthma? And you have also to check for comorbidities like rhinosinusitis, GERD, obesity, OSA, depression, anxiety, since this may contribute to symptoms and poor quality of life. So with regards to symptom control, in the past 4 weeks, had the patient had daytime asthma symptoms more than twice a week, any night waking due to asthma, reliever needed for symptoms more than twice a week, any activity limitation due to asthma. If you have 1 or 2 of this, you have a partly controlled asthma. 3 or 4 of this, you have uncontrolled asthma. Also, assess the risk factors for poor asthma outcomes. And it should be assessed at diagnosis and periodically. Measure the FEV1 at start of treatment, after 3 to 6 months of treatment, and records the patient's personal best. Assess patient's risk for exacerbation, fixed airflow limitation, and medication side effects. So in the GINA 2019, for children 6 years old and above and adolescents, the reliever, they just clarified that the reliever should be SABA. So the risk factors for exacerbations include the following: if they have uncontrolled asthma symptoms, and if the patient has few symptoms, however, there's a high SABA use, 1 exacerbation in the last 12 months, low FEV1, incorrect inhaler technique, smoking, obesity, or the presence of comorbids, ever intubated for asthma. The risk factor for fixed airflow limitation, it is now changed to persistent airflow limitation rather than the fixed airflow limitation, such as no inhaled corticosteroids treatment, smoking, occupational exposure, preterm birth or low birth weight, or sudden weight gain. The risk factors for medication side effects, which include frequent oral steroids or high-dose potent inhaled corticosteroids. So for children less than 5 years of age, as you can see here, there is major psychological or socioeconomic problems for child or family, and this is the risk factor for asthma exacerbation and outdoor pollution. And the risk factors for persistent airflow limitation is the history of bronchiolitis and severe asthma with several hospitalizations. And risk factor for medication side effects are actually moderate to high dose potent inhaled corticosteroids, incorrect inhaler technique, and failure to protect the skin or eyes when using inhaled corticosteroids by nebulizer or spacer with face mask. So how do we assess the asthma severity? It should be assessed retrospectively from the level of treatment required to control the symptoms and exacerbations. When to assess? And you assess the asthma severity after the patient has been on controller treatment for several months. And for the categories of asthma severity, patient has mild asthma if the symptoms have been well controlled with steps 1 or 2, or moderate asthma well controlled with step 3, or severe asthma which requires step 4 or 5, or remains uncontrolled despite this treatment. So let's now go to the principles of asthma management. The long-term goals are to achieve the good control of symptoms and maintain normal activity levels, minimize future risk of exacerbation, fixed airflow limitation and side effects, and establish good patient healthcare provider partnership, and observe the control-based asthma management cycle. So for the symptom control, check on the presence of the symptoms, no sleep disturbance, no exercise limitation. For the risk reduction, maintain normal lung function, prevent flare-ups, prevent asthma death, avoid medication side effects. So we have the management of asthma, the general management, and also the asthma medication, treatment of modifiable risk factors, treatment of comorbidities, non-pharmacological therapies and strategies, follow-up, and other therapies which are reserved for step 4 and step 5, or for those with severe or difficult to treat asthma, such as allergen immunotherapy and bronchial thermoplasty. So this is your control-based asthma management cycle. So for here, it is a continuous assessment, adjust, and review response. And it takes into consideration also a shared decision between the patient or the parent, and also the satisfaction of your patients. So what are the therapeutic options for asthma? You have your bronchodilators such as, and this could be either short-acting or long-acting, and beta-2 agonists, salbutamol and procaterol are your short-acting. Long-acting is salmeterol and formoterol. Bronchodilator is also your anticholinergic, ipratropium, and your long-acting anticholinergic tiotropium. Anti-inflammatory drugs are your inhaled corticosteroids, leukotriene modifier agents, or a combination therapy of your inhaled steroids plus LABA and systemic corticosteroids. So for the therapeutic modality for asthma, your reliever is used for bronchoconstriction and during asthma attack, whereas, and this include your rapid onset of action and potent bronchodilator. And for your inflammation and airway hyperactivity, we use your controller. And these are the steroids, anti-inflammatory drugs, and the rest. So the key differences among bronchodilators are depending on the onset and duration, receptor selectivity, and intrinsic efficacy. And you have a rapid onset of action, short-acting bronchodilator, and these are your salbutamol, terbutaline, and procaterol. You can also have your slow onset of action with long-acting effect, which is salmeterol, and formoterol is a rapid onset with long-acting effect. So what are the differences of oral procaterol and oral salbutamol? Onset of action is the same, 30 to 60 minutes. However, the duration of action of procaterol is 10 to 12 hours compared with salbutamol, which is 4 to 6 hours. In terms of receptor selectivity of beta-2 adrenergic receptor agonists, your third generations, which includes your procaterol, formoterol, salmeterol, is more selective with your beta-2, and the duration of hours is longer. What about the comparative beta-2 adrenergic receptor selectivity? your isoprenoline as your guide, your procaterol has 11.1 times beta-2 selectivity compared with the isoprenoline. The values of intrinsic efficacy of beta-2 agonists, which is measured as a physiologic response in airway smooth muscle, your beta-2 agonist formoterol, procaterol, and isoprenolerol has an intrinsic efficacy of 100% compared with salbutamol, which is 81%. Procaterol significantly inhibited the reduction in pulmonary flow rates in peak expiratory flow rate on nocturnal asthma, as shown in this graph. Here's your procaterol, and here's your placebo. And also, procaterol significantly decreased the amount of nocturnal wheezing during the early time of the nocturnal asthma, especially during the 4 a.m. time, as you can see here. What about the comparative study of the protective effects for exercise-induced asthma of beta-2 stimulants? This is a local study done by Dr. Tuasan and Dr. Untalan at UPPGH on exercise-induced asthma, which showed that procaterol protected the subjects from EIA, and this is comparable with your salmeterol. Salbutamol, on the other hand, showed no more protective effects after 5 hours of its administration. And this long-term protection from EIA is beneficial, particularly to children and even adults in enjoying their daytime activities in school at work. Another local study done was the inhaled procaterol versus inhaled salbutamol in mild to moderate asthma attack in children 6 to 18 years of age. And this is a randomized single blind wherein patients were grouped to salbutamol, 2 puffs given every 20 minutes for 3 doses, or procaterol, 1 puff 20 minutes apart for 3 doses. And the criteria that were taken were the PFR, modified Wood down score, cardiac rate, and respiratory rate. And these were the results. The mean change in your PFR is higher in the procaterol group compared with your salbutamol group. The change in the modified Wood down score is also greater in your procaterol group. And those on your procaterol group actually has less increase in the heart rate compared with the salbutamol group. The comparative study on bronchodilating effects of procaterol and salbutamol in terms of onset of action is within 5 minutes, but on the 15th, 30th, and 60-minute procaterol had a significantly higher peak flow compared to your salbutamol. So aside from asthma, the procaterol can also be used in chronic bronchitis and pulmonary emphysema and treatment of acute bronchitis. It is an ideal option for acute bronchitis since it can decrease the frequency of cough. It can also decrease the severity of cough, and it can also improve the excretion of the sputum. So let's now go to the key changes in GINA 2019. And in GINA 2019, a fundamental change in asthma management was observed. And the background to changes in 2019 is that the risk of the mild asthma, patients with apparently mild asthma are at risk of serious adverse events. And exacerbation triggers are variable, which can either be virus, pollen, pollution, or poor adherence. Inhaled SABA has been the first-line treatment for asthma for 50 years, and this dates from an era when asthma was thought to be a disease of bronchoconstriction. Patient satisfaction with and reliance on SABA treatment is reinforced by its rapid relief of symptoms, its prominence in emergency visits, and department and hospital management of exacerbations, and low cost. And patients commonly believe that my reliever gives me control over my asthma, so they often don't see the need for additional treatment. The regular or frequent use of SABA is also associated with adverse effects due to its beta receptor downregulation, decreased bronchoprotection, rebound hyperresponsiveness, and decreased bronchodilator response. Higher use of SABA is also associated with adverse clinical outcomes. Dispensing more than 3 canisters per year is associated with higher risk of emergency department presentations, and dispensing more than 12 canisters per year is associated with higher risk of death. So for step 1, this is the major change. Previously, no controller was recommended for step 1 in adolescents. However, for step 1, as needed low-dose inhaled corticosteroids formoterol is now the preferred controller. And SABA is no longer a preferred controller for this option. For safety, GINA no longer recommends SABA-only treatment for step 1. And this is based on the risk of severe exacerbation, and that adding inhaled corticosteroids significantly reduces the risk. GINA now recommends that all adults and adolescents with asthma should receive inhaled corticosteroid-containing controller treatment to reduce the risk of serious exacerbation. And this can be delivered by regular daily treatment or in mild asthma by as-needed low-dose inhaled corticosteroid combination formoterol. Step 2 change is that the daily dose inhaled corticosteroids or as needed low dose inhaled corticosteroids formoterol. And the controller option, you now have several options. So you have 2 preferred controller options: regular low dose inhaled corticosteroids with as needed SABA, or as needed low dose inhaled corticosteroids formoterol. And other controller options are low-dose inhaled corticosteroids taken whenever SABA is taken. And low-dose inhaled corticosteroids, another option is leukotriene receptor antagonist. However, this is less effective for exacerbation. So other changes in GINA 2019, steps 3 and 5 for adults and adolescents is that there's no theophylline in your other controller option for step 3. For step 4, treatment is medium low dose ICS LABA. High dose is now in step 5. And for step 5, high dose ICS LABA and the use of your anti-IL-5R and anti-interleukin 4R. And your maintenance oral corticosteroids is not a preferred option at step 5 due to serious side effects. For children 6 to 11 years, it's still the same. However, there's an emphasis on the personalized asthma management. And patients, you have now your asthma medications adjust down or up. And a holistic approach, not just symptom control. So it's now a shared decision making with the patient and the parent. And this, which should include the preferred treatment, the patient characteristics and preference, and your practical issues such as technique, adherence, and cost. So step 1, it's the same for step 2, 3, 4, and 5. For 5 years and younger, it's still the same. So the major change is actually in the adolescents and in the adults. In here, I just underlined the personalized asthma management, since it's now a shared decision between the patient and the parent. And inhaled corticosteroids at onset of respiratory illness is also an option as other controller option for your step 2. And before, in patients on step 4, are those who are referred to your specialist. However, for patients on step 3, wherein they use a double low dose inhaled corticosteroids, you may consider referral to specialist. So With these diagrams, where to start? Should all patients start at step 1? Actually, it depends. So if the patient has infrequent asthma symptoms less than twice a month, your as-needed low-dose inhaled corticosteroids formoterol can be given for adolescents, and other options will be inhaled corticosteroids with SABA. Asthma symptoms or need for reliever twice a month or more, low-dose ICS with as-needed SABA or as-needed low-dose ICS formoterol. Troublesome asthma symptoms most days or waking due to asthma once a week or more, especially if any factors exist, then low-dose ICS LABA as maintenance with ICS formoterol as your reliever, or conventional maintenance treatment with as-needed SABA as your reliever. And the other option is medium-dose ICS. Initial presentation is with severe uncontrolled asthma with an acute exacerbation. You may opt to give your short course oral corticosteroids and start regular controller treatment with high dose ICS or medium dose ICS. Before starting your initial controller treatment, record evidence for the diagnosis of asthma, record the patient's level of symptom control and risk factors including lung function, consider factors influencing choice between available treatment options, ensure that the patient can use the inhaler correctly, schedule appointment for a follow-up visit. After starting initial controller treatment, review the patient's response after 2 to 3 months or earlier depending on clinical urgency, and step down treatment once good control has been maintained for 3 months. So this is just a suggested initial controller. This was also discussed on the previous slide, but for us to be more adept in using this, if your patient is in symptoms less than twice a month, step 1. Symptoms twice a month or more but less than daily, step 2. Symptoms most days or waking with asthma once a week or more, step 3. And symptoms most days or waking with asthma once a week or more and low lung function, step 4. So these are for adolescents and adults. For children 6 to 11 years of age, it's the same. Step 1 for those symptoms less than twice a month. Step 2 for symptoms twice a month or more but less than daily. Step 3, symptoms most days or waking with asthma once a week or more. And then step 4 for those with symptoms most days or waking with asthma once a week or more and low lung function. For children less than 5 years of age, the goals of asthma management is similar to those in older patients. And wheezing episodes in young children should be treated initially with inhaled SABA, regardless of whether diagnosis of asthma can be made. A trial of controller therapy should be given if symptom patterns suggest asthma and alternative diagnoses have been excluded. And response to treatment should be reviewed before deciding whether to continue it. And reconsider alternative diagnosis if the response is absent or incomplete. And the choice of the inhaler should be based on the child's age and capability. The preferred device is pressurized metered-dose inhaler and spacer with face mask for less than 3 years, and those for 3 to 5 years are those with mouthpiece. So how do we step up? You can do short-term step up for at least 1 to 2 weeks by the clinician or by the patient with a written asthma action plan, especially during viral infection or allergen exposure. Day-to-day adjustment by the patient prescribed with as-needed low-dose inhaled corticosteroids formoterol for mild asthma or low-dose inhaled corticosteroids formoterol as maintenance and reliever therapy. Stepping up asthma treatment, sustained step up for at least 2 to 3 months. If the symptoms or exacerbations persist despite 2 to 3 months of controller treatment, assess the following common issues before considering stepping up, such as incorrect inhaler technique, poor adherence, modifiable risk factors, and comorbid conditions. Now, how do we step down? If there's good asthma control for 3 months, then you can step down. Choose an appropriate time for stepping down. No respiratory infection, patient not traveling, not pregnant. document baseline status, symptom control, and lung function, give written asthma action plan, monitor closely, and book for a follow-up visit. So we have, the next 3 slides will be the tabulation and the low, medium, and high dose of different inhaled corticosteroids. Mind you, this is not a table of equivalence. These are just the suggested total daily doses for low, medium, and high dose treatment options. And these are based on available studies and product information. And this does not imply potency equivalence. So low dose inhaled corticosteroids provide most of the clinical benefit for most patients with asthma. Sometimes some patients will not respond, so you may need your moderate dose, and high dose inhaled corticosteroids is needed by very few patients. So for adults and adolescents 12 years old and older, since what we have in the market here in our country is beclomethasone, budesonide, and fluticasone. So for beclomethasone, low dose for adolescents is 200 to 500, medium is 500 to 1000, 1000 is your high dose. For fluticasone, 100 to 250, medium is the 250 to 500, more than 500 is the high dose. And your budesonide is 200 to 400, 400 to 800 medium, and 800 is the high dose. So for children 6 to 11 years of age, beclomethasone is 100 to 200 low dose, and the 400 is the high dose. Your fluticasone is 50 to 100 low dose, more than 200 is the high dose. Budesonide is 100 to 200 for low, medium is 200 to 400, and more than 400 for the high dose. And of course, for children 5 years and younger, the dose is much smaller. So what about your Montelukast? There's an FDA box warning in March 2020 about the risk of serious neuropsychiatric events, including suicidality with Montelukast. And these are reported in adults and adolescents, and also nightmares and behavioral problems in children. So before prescribing Montelukast, health professionals should consider the benefits and risks, and patients should be counseled about the risk of neuropsychiatric events. So we're now down to your interim guidance on asthma and COVID-19. And for those with asthma and or allergies, the GINA 2020 guideline on COVID and asthma, avoid nebulizers where possible, since nebulizers increase the risk of disseminating virus to other patients and to healthcare professionals. Advise patients with asthma to continue taking their prescribed asthma medications, particularly inhaled corticosteroids and oral corticosteroids if prescribed. Make sure that all patients have a written asthma action plan. Avoid spirometry in patients with confirmed or suspected COVID-19. Follow strict infection control procedures if aerosol generating procedures are needed. Follow local health advice. And the American College of Allergy and Immunology recommends continuing or resuming your asthma routine that helps control your symptoms. Use short-acting rescue medications for as needed for symptoms. Follow the asthma plan. Follow CDC guidelines. If you have upcoming appointment with your allergist, please call to confirm. Many allergists are using telemedicine for return appointments. Contact your allergist if you have questions about your medications or symptoms. So I would just like to share with you, if your patient is intubated, you can still use your metered dose inhaler, and it is much less in terms of price and in terms of personnel. These are the commercially available inline meter dose inhaler spacing device. Okay, so it is attached, the endotracheal tube is, and this is the Y tube of the patient, or the Y piece, and this is where it is attached. There's a local study wherein, since it is not readily available in other countries, also in our countries, we can make use of the elbow, and this is to the patient, and this is from the circuit, okay? And drill a hole on top of the elbow. So this is how it will look like. Okay, so this is the elbow. They drilled a hole and attached to the circuit, and this one is attached to the patient. So take-home message, all adults and adolescents with asthma should receive inhaled corticosteroids containing controller treatment to reduce the risk of serious exacerbations. SABA-only treatment is no longer recommended as the only treatment for step 1 in adults and adolescents. Shared decision-making with the patient-parent in asthma management, and avoid aerosol-generating procedures during this pandemic. Thank you so much for your kind attention.